Good afternoon, all. So today's topic of discussion is CRRT, which is a bit complex topic for discussion, but I will give only overview. I will not discuss the how to calculate the dosage and all. So starting with, we'll discuss the briefs of these are the content topics. CRRT is, if you see, it's a mutual discussion and understanding, and then agreement between an intensivist and a nephrologist to go for it or not. So without disagree, means if any of the person is disagreeing to it, we don't usually go for it. First CRRT was done in 1977, and there was no blood pump integrated to it. It was just because of the arterial pressure. Next, in 1994, Gamro did first CRRT. Gamro is a company, and it developed the machine in which there was a blood pump. So venous CRRT was done. Now, if you see, CRRT has replaced 90% of the ICU dialysis in Australia. In Europe, almost 60 to 70% AKIs are dealt with CRRT, and in US it is 30%, and it is increasing. But if you see in India, it is still 5% of the, and if you see in Gujarat particularly, the highest number of CRRTs are being done in SIMS, if you know. So CRRT is nothing but extended dialysis. There are some principles of which makes it superior to hemodialysis, but it is nothing but an extracorporeal blood purification therapy, and it is intended to substitute impaired renal function over an extended period of time. So it works for 24 hours, 48, 72, any amount of time which we require it to function. Why do we require it for 24 hours or more? We discuss it in further slides. So CRRT mimics the native kidney. It is slow, gentle, and continuous. It is well tolerated by hemodynamically unstable patients. So this is one of the main indications why we go for CRRT, because the hemodynamics are poor, patient is on triple inotropic support, and we require a slow and stable therapy. It prevents further damage to the kidneys because the blood flow rates and all the fluid flow rates are very low, and it promotes healing and renal recovery. It also helps in regulation of electrolytes and acid-base disturbances, which are less smoothly regulated in dialysis, hemodialysis. And it allows us to remove large amount of fluids or waste products over a specific period of time. Means if we want to remove 3 liters of fluid in hemodialysis of 4 hours or 6 hours duration, it is there are risks that the blood pressure of the patient may go down. But if the same amount has to be removed in 24 hours, then we achieve a good stability hemodynamically. And so clinical indications of CRRT, there are renal indications and non-renal indications. So main renal indications which you all know is acute renal failure, and sometimes azotemia, which is a part of acute renal failure, and fluid overload. So even if the patient does not have any renal dysfunction, it can, if there is fluid overload, as in cardiac patients who are having heart failure, we can put them on CRRT just to remove fluids stably. And some non-renal indications are drug overdose. Sometimes what happens is if you question that drug overdose can be removed in hemodialysis. So some drug molecules are only removed by convection principle, which is only there in CRRT and not in hemodialysis. Then cerebral edema. So how CRRT helps in cerebral edema? So in case of cerebral edema, if we do large changes in the fluids, if we remove much of the fluid, or if there are sodium imbalances which are more common in hemodialysis, there are chances of permanent brain injury. So in cerebral edema, we prefer CRRT over SLED or routine dialysis so as to prevent brain function. Then metabolic disorders. Next is crush injury. Crush injury, what happens is there is increased level of myoglobin. Now myoglobin is less removed by hemodialysis. It is removed by CRRT. So crush injuries, we prefer CRRT. Sepsis and ARDS, again, the cytokines which are not removed by hemodialysis are being removed by CRRT. So we prefer CRRT over hemodialysis in these two indications. So perceived advantage, which I already discussed, it allows adequate volume of the nutrition without compromising the fluid balance. Main advantage is decreased vasopressor requirements during fluid therapy. So if you, all those consultants in whose patient I have done CRRT, most of the times you might have seen that there is decrease in the requirement of vasopressors over a period of time, which we easily achieve with CRRT. Then obviously other advantages like which we discussed, increase hemodynamic stability, optimizing the fluid balance in lung injury, and continuous control of fluid balance. So if we see the components of CRRT, this is the machine. It has a hemofilter. It has different solutions, Prismasol or Regocid Bifosil. We have to, one of the major component is anticoagulation, which we have to think about, because there is a problem in CRRT that the cartridge gets clogged. And as you are very much aware, the therapy is costly. So a single cartridge costs around 20,000. So if it doesn't run more than 24 to 48 hours, there is some mistake on our part that we are not able to properly anticoagulate the patient. Then vascular access. So vascular access is also an important component of CRRT. If the flow is not smooth, then there are chances of thrombosis and the cartridge may clot. Blood warmer. So in CRRT, what we have seen in 2-3 patients, that because of this continuous flow, continuous duration of therapy of 24-48 hours, there is hypothermia in the patient. So we have a warmer attached to it. So about anticoagulation, there are 2 types of anticoagulations, heparin and citrate anticoagulation. We use both in our setups here. Membranes, if we discuss, there are specialized membranes available in CRRT, one of which is Oxiris, which helps us removal of endotoxins and cytokines. So a different cartridge, which you must have heard, cytosorb is not required to be attached. Warmers we have already discussed. So now the most important thing is principles of CRRT, which are ultrafiltration, diffusion, convection, and adsorption. So in short, a little bit. First, we will discuss what molecular weights are removed. So the lower portion, pink portion, are all the small molecules like urea, creatinine, and phosphate sodium. These small molecules are well taken care of by hemodialysis. About this, the blue portion and the green portion are not removed by hemodialysis. Here is the thing where the CRRT comes into place. So the uric acid, glucose, vitamin B12, inulin, and I will continue now. And one important thing is the large molecule albumin. So albumin is not removed by CRRT. So we can very much give it with CRRT. So ultrafiltration is nothing but just passage of fluid from with a semi-permeable membrane. So ultrafiltration is the modality when you are only required to remove the fluids. Diffusion is both a primary mechanism in hemodialysis and a secondary mechanism in CRRT. Here only the solutes transport of solutes occur from the higher concentration to lower concentration. So the patients who have renal failure have accumulation of these toxic materials, they diffuse through the membrane. And this is the main principle of CRRT, convection, which we don't get in hemodialysis. In this principle, what happens is there is a solvent drag. So we give lots of fluids along in the machine as a replacement fluid, and this fluid removes those middle molecules which are not removed in dialysis. Middle molecules as in cytokines and endotoxins. So these fluids drag them with themselves across the membrane. So for this principle, we use CRRT particularly. And adsorption is you all know the molecules get stick to the membrane, but this is a least important principle in dialysis. So moving to the main slide. So we can do 4 modalities in CRRT. SCUF, it is slow continuous ultrafiltration, as I discussed in cardiac patients, only for the removal of fluid. Continuous veno-venous hemodialysis is nothing but a hemodialysis, but it is a prolonged hemodialysis without the use of convection principle. Then CVVH, it is continuous veno-venous hemofiltration. It is just convection, not doing dialysis. only for the removal of middle molecules. And what we usually practice is combination of both CVV HDF. CVV HDF is continuous veno-venous hemodiafiltration. It means we are doing dialysis along with removal of middle molecules, and this is the modality which we routinely use. So last slide. What is the ideal dose of CRRT? So ideal dose is 20 to 25 ml per kg per hour, but how to calculate this dose is a complex thing not to be discussed here, just for your knowledge. And this is the screen which you see usually in the CRRT machine, and on the this red highlighted portion are the pressures. Below here, if you see, TMP is the pressure, transmembrane pressure of the cartridge. If it goes above 150, means the cartridge is near about to clot. And this is the main component of the flow parameters: blood flow rate, the replacement fluid rate, dialysis rate, and patient fluid removal. And here you can get a dose also. This is 38 ml per kg per hour. Example is here. So thank you.